Case of psoriatic arthritis. So there was a 32-year-old male with severe psoriatic arthritis of bilateral hip and knee, that is 4 joints. There was a flexion deformity of bilateral hip with abduction on the left side and the adduction on the right side. Flexion deformity of bilateral knee, right 120 and left 90 degrees. There was deformity of the bilateral wrist, feet and hand, and the patient had active severe psoriasis with more than 30% of skin lesions, and the patient was on retinoids. To add to this, patient was also diabetic and he was bedridden for more than 7 years, and he has been said that he will not be able to stand up. Right. So this is his clinical pictures. You can see the deformity, almost posteriorly subluxated. The opposite side even more severe. And you see the skin was so thin that each part of the bone is visible almost transparently. The deformity in the hands, feet. Now the x-rays. This is x-ray of his hip, a bilateral knee, AP. The lateral view, almost. This is the CT scan of the knee. And this is his hip, both hip fused with the stress fracture.
You were saying fused because it's radiologically fused, it's not radiologically ankylosed.
So radiologically, we have the CT also.
We have CT.
So the CT is there. So it is fused. There is, you can see that posteriorly it is continuously fused. There is a stress fracture also.
No, do you have the sections of the CT showing?
Yes, sir, we have. Almost fused.
So that is not bony ankylosis. That is basically
almost. Yeah, there is almost.
Yeah, it's a fibrous situation. Very good.
And to add to the problems, patient was Ayushman patient.
Ayushman Bharat.
Yeah. So, what should we do, sir? What will be?
No, I think you tell us your thought process, what you did, and then we'll.
So this patient has multiple problems. He was having arthritis mutilans, the most severe form of arthritis, psoriatic arthritis.
So basically, he was on immunosuppressants. Did you stop the immunosuppressants?
Yeah, he was in retinoids and he was diabetic also.
Okay.
On insulin.
So what is his HbA1c?
Sir, I don't remember, but we controlled it. Pre-operatively, we controlled it. Then only we did it. He was a young patient with problems of ankylosed hip, difficulty in exposure and the neck cut, sciatic nerve injury, reduction, everything. Then there was problem in the knee also. That is, when you are correcting such a severe deformity, there is a risk of neurovascular compromise, problems in gap balancing, poor, and then you have seen in the clinical picture, very poor soft tissue. And how much to correct, pre-operatively, intraoperatively, or leave it for post-operatively, or whether we require a constant or hinge. So we decided that we will do some correction before the surgery. So we did a bilateral tenotomy of the hamstrings, put him on traction and serial casting. And then we did the rest of the correction intraoperatively. But this was causing taking much of time of the patient, and patient was in hurry. So we ended up into something else. Someone tried, another surgeon tried to do it. So then it became more complex.
What did the previous surgeon try to do?
Sir, someone tried to do a total hip, but while doing the hip, they have cut everything. Now we have this. So there is almost no acetabulum, nothing, and so complications and then more complications.
Go ahead.
No. Then what we did, we did a total hip on the left side, which was normal. And
The two screws for the GT are for the trochanteric osteotomy?
yeah, no, sir. There was see, the bones was very osteoporotic. He was bedridden for 7 years and cachexia also. So therefore, that while reducing it, I found there was a small split. So that's why we have put 2 screws. Then we got a CT, and the right side acetabulum, almost there is no acetabulum. There is a thick bone like iliac crest. Then we did
So
both
you didn't
the
do
knees
anything on, you didn't do anything on the right side at this stage?
so I'm coming on. Then we did both the knees. In the first sitting, I did the left hip and the left knee, which were normal. Then next sitting, I did the right knee, and we have left the that one for the later one. So this is his. So we were almost to get a good correction intraoptically in the knee also. It was almost 120 degrees. Then I decided that I will go in a stage wide on the right hip. So on the right side, we did, so it was fused, all fused, you see, it was fused. So where we went in and we just put the cup because it was not coming down, so very osteoporotic and the risk of infection was very high to do a subtrochanteric osteotomy or do something like that, plus Aishwan constraints are there. So we did the cup and we put a small mesh and we tried to put, there was no acetabulum at all. It was like a thick bone of iliac crest. So you even don't have a finger to put in any acetabulum. So what we did, we just trimmed it, put some cage and, you try to make some sort of acetabulum. And then in the next sitting, we did a complete replacement.
Yeah, I think
Yes.
the bone graft was
Yeah,
there.
bone graft Sir, there was no bone graft actually. Whatever was left, that you have to use. And I have used, yes, I have used some hydroxyapatite and Jibun there.
Regarding the knees, you just used a PFC knee,
Yes,
isn't
sir.
it? Could you actually straighten it out from 120 degrees?
Sir, what I did, we did 30% correction pre-operatively by hamstring tenotomy, traction, and serial casting. That was the time taking that the patient, somebody.
But even then, you have a deformity of like 75, 80 degrees.
Yes, it was. Then we have corrected almost up to, about 60, 70 degrees intraoperatively. And the rest by physiotherapy.
I would have been inclined to put 2 hinges in the knee and done a
And this is
distal
his,
femoral
walking
resection and
video.
then
So
put a
almost
hinge, yeah.
both the knees have straightened out. He has sent us from house.
No, I will say congratulations. I think it was a phenomenal effort. So,
And then,
you
Aishman
obviously got a fantastic result. So, for that,
Good done.
congratulations. Yeah.
My God, after seeing the X-ray, I never expected this outcome.
Very good.
Sir,
Radiological.
the physiology of what I thought, even if it becomes loose, I will make a small acetabulum around it. And with the time, there will be some bone formation with the graft. And probably I will have to revise it after some time. But luckily,
And God has been kind to both of you.
God has been also
Actually, what worked in your favor was even what you thought was an ankylosing was a fibrous ankylosis. So basically, if you look at the CT and the X-ray closely, it's not a bony ankylosis. So it's a
there was
fibrous.
no even job of money. He was bedridden for 7
No,
years.
no,
almost.
but if you look at study the X-ray and the CT, no, I agree with you perfectly, but that helped you a little further, I
Yeah,
said.
that's small.
That's very good because you got a good cup hold on the other side, and this side also you made sure you made use of whatever graft was available. Very good.
Even after seeing the CT scan, I was very skeptical where cup is going to be.
So there was no, it was like a thick band, like iliac crest. But luckily we were able to get it away.
Femoral head on the left side can be used on the right side. You have done a nice job.
As a bone graft.
Both time I was not there on that time, when it has happened. So it was not in my hands.
But
And you can't do, same sitting. So patient is so much diabetic that he is on not that normal insulin, 40 units per ml. He is on 100 units per ml insulin.
anyway, whatever, we can't ensure the life, whatever life he has, he will be walking. That's the best thing. And let's wish Dr. Ajit Singh, it is his birthday today. So,
Happy birthday from all of
happy
us.
birthday, sir. Just got to know.
Very good day to present as well.
Shows he's an inborn surgeon. Born today.
That is a bony ankylosis, yeah, correct.
So the take-home message was that, someone who has no experience should not try such type of cases or osteotomy, at least in an ankle. If somebody has no experience, he should not try the neck cut.
Yeah, that's a bony ankylosis. That is different
So
from
that's
what...
why I've taken how should the cut should be taken.
Correct. That's in a bony ankylosis, but
This
the
one-
other one
this
is
one is
not a bony ankylosis. Anyway, very well done, very well done.
Okay, sir. Thank you, sir.
Next, we call upon Dr. Kumar Keshav for his presentation. Yeah.
So, hello, good afternoon, everyone. I would like to really thank Dr. A.S. Prasad sir and Dr. Anand Nigam sir for giving me this opportunity. Actually, it's not a case, individual case, but it's a case series that how I have started doing the 360-degree exposure of the acetabulum. Like in the initial part of my career, I found that the major obstacle for me when I moved from hemi-arthroplasty to total hips was the exposure of the acetabulum. So that was one step which I found I was not well trained during my residency. And I did some fellowships, and then I found that this step I was not able to do it in a convincing manner. So eventually, after doing a certain number of cases, I zeroed in on my way of doing this 360 exposure. And I would like to share this with my younger colleagues. I know that for the senior people, this is a very easy thing to do, but for the young people who are just starting out, 360 exposure seems good to hear, but then doing actual 360 exposure is a bit difficult. So I would like to share you the way I did this 360-degree exposure of the acetabulum in my 45 primary total hips. So as we all know that if you do not expose the acetabulum completely, you can have inadequate or eccentric reaming, which can lead to poor osseointegration and aseptic loosening. And also, if you are not able to visualize the tile completely, you can put your acetabular component in some kind of retroversion or increased antiversion. And for exposure, the retractor placement is the key. Now, which retractor, whether pin should be used, whether cobra retractor or a simple Homan retractor, those things I am going to discuss over here. And if you use the retractor and retract too much, then it can also lead to some kind of neurovascular damage. Now, just to brief like what exactly I do in my technique is I put two pin retractors, one superiorly and one on the posterior aspect, and two cobra retractors, one anteriorly and one inferiorly. Like this is an orthogonal placement of pins, so it's easy to remember, and I can guarantee you that it's easily reproducible because I have done it in many cases. Now the pin retractors, the first pin retractor goes at 12 o'clock positions after we have retracted the abductors. Thereafter, I take off the posterior capsule, a part of the posterior capsule from the posterior edge of the acetabulum and put a pin retractor on the posterior aspect. Now, many people will argue why not a simple Homan retractor and why a pin? Because many times when your other residents are watching you doing the case, they often try to peek inside and they retract it too much, and that can cause some kind of iatrogenic sciatic nerve palsy. So, if you put a pin, then you are dead sure that you are not going to retract it beyond a certain limit. And also there is a cushion of capsule, posterior capsule and short external rotators between the edge of the acetabulum, between the pin and the sciatic nerve. So that protects your sciatic nerve. Now I use two cobra retractors. The first cobra retractor goes anteriorly after I have taken off a part of the anterior capsule and the reflected head of the rectus femoris. Now this many times if you do not place this retractor in a proper manner, what happens is that you break the anterior wall, a part of the anterior wall, and then your acetabular cup does not go properly. So just to avoid breakage of the anterior wall, we have to ensure that the cobra retractor goes more deep compared to what we often see people doing. And then comes the inferior retractor. The inferior retractor is placed just under the tile, but many times the base of the acetabulum is a bit soft, and if you try to retract it too much, the tip of the retractor may go inside the acetabulum, and while you are reaming, the reamer may strike the tip of this thing. So what I do is that I hook it at the superior margin of the obturator foramen. I mean, most of the people are doing it this manner, but this is since you can remember it easily, like orthogonal placement of the pins, it's easily reproducible. Now, before going for the surgical video, I would like to show on the bone model where I have exactly, this is the superior and the posterior aspect, we place 2 pins, and on the inferior and the anterior aspect, I have put 2 cobra retractors. Now let's go with the surgical video. So once I reflect the gluteus medius anteriorly, I take a Hohmann, I just take the retractor, gluteus medius and minimus anteriorly, put a pin retractor over there. Now comes the exposure of the anterior capsule and the other soft tissues present supero-anteriorly and anteriorly. So for doing this, I take a bone hook and I take the femur up. I ask my assistant to hold it up so that the whole of the anterior capsule is visible. And then you are just taking off the capsule from the acetabulum and not the femoral side. So once you put your retractor, you have to go a bit anterior to the capsule, and then there is a cushion of iliopsoas muscle which protects your femoral vessels. Now coming to the posterior aspect, often the posterior capsule drapes the acetabular cavity, so you have to take off a part of the posterior capsule. Then I am trying to take off the posterior capsule from the edge of the posterior acetabulum, and the sciatic nerve is usually around 2 centimeters behind the edge of the acetabulum. So I put this pin just around 1 centimeter behind the edge of the acetabulum, in such a way that once I have done reaming, the tip of the pin is not going to come in the way. Then comes the tal. So we have to take off the part of the inferior capsule, and identification of tal is one thing which I struggled during my initial days, because many a times what I thought as tal was in fact a part of the inferior capsule. So you have to identify the tal, and then you have to create a rent between the tal and the inferior capsule and try to hook this Hohmann as shown in the bone model on the superior aspect of the obturator foramen. And that completes the 360 exposure of the acetabulum. So I try, once after doing 20-25 cases, I tried to replicate this in all my cases. And so this case series was basically a retrospective analysis of prospectively collected data. I took photographs of all my cases and asked one of my senior colleagues to assess whether I was able to successfully do 360 exposure or not. And any intraoperative or postoperative complications were also noted down. So I operated on 45 hips by this method in 33 patients, out of which 31 were males. And I used this technique in various etiologies. Like most often the patients that we get at our center are referred from the immunology department of our institute. So most of the cases were either AVN because of steroid intake or angst and other inflammatory arthropathies. In one of the cases, I used this technique in dysplastic hip, and also in few cases of failed hemiarthroplasties. I have very low threshold for doing an in situ osteotomy because I do not want to fracture the posterior wall or the femur. So I did in situ osteotomy in 10 patients, 6 for ankylosed hips and in 4 cases of protrusio acetabular. So desired 360 exposure was achieved in all our cases. However, in 5 cases, we had to use additional retractors. Most often, we had to use additional retractor on the postero-inferior aspect. Now, the complications that we encountered in our study were partial breakage of the anterior wall in 3 cases and over-reaming of the posterior wall in 2 cases. And in the post-operative complications, there were 3 cases had some anterior groin pain, most likely due to the placement of the inferior retractor. And there was 1 case of angst where we encountered sciatic nerve neuropexia, but that has recovered over the next 6 months. The average follow-up was 6 months, but I don't think that this study was more to do with the exposure rather than the follow-ups. So I don't think that long-term study is really required in this. Now coming to the discussion part. What are the structures which are at risk and which should be we should be aware of, and is there any thing to be scared about? So the placement of the superior retractor is important from the perspective of superior gluteal nerves and vessels. The safe distance is 1 inch from the edge of the acetabulum. So if you put your pin within an inch of the superior edge of the acetabulum, you are pretty safe. Now various cadaveric studies have shown that the superior gluteal nerves and vessels run around 1 inch to 2 inches away from the edge of the acetabulum. So, but the nerve palsies have been seen more often in anterolateral or the Watson-Jones, the Harding and the trans-trochanteric approach and not the posterior approaches. Now coming to the anterior retractor, this is one thing which people are often much scared about. So the technique that I showed, like lifting off the femur by the bone hook and exposing whole of the anterior capsule is the crux, like so that you can release the capsule from the acetabular side and not midway. And then if you put the cobra retractor, and there is a sheath of iliopsoas which protects the femoral vessels. However, if you are not careful enough, you may land with some kind of intimal damage of the femoral vessels, which can give rise to some kind of false aneurysm. Case reports have been cited on this topic. Now coming to the posterior aspect. Sciatic nerve, as we all know, especially in dysplastic hips, tight hips, the sciatic nerve is very close to the edge of the acetabulum. So you have to be careful in those cases. But still, in those cases, if you try to take the hip in extension, the sciatic nerve falls in a bit of less tension, and then you can put your posterior retractor in that case. Often, the sciatic nerve is around an inch away from the edge, so you have got quite a safe distance over there. Now coming to the inferior retractor, the obturator neurovascular bundles are there, so it's a dangerous place, I accept that. But then the direction of the tip of the retractor is in the same line as the direction of the obturator vessels are traveling. So if you are a bit careful, I don't think that it's going to damage. In no case of ours, we had any kind of major bleeding. However, in one case, while we were taking off the inferior capsule, we had some kind of severe bleeding. So in that case, I had just did pack and pray. And after 10 minutes, I found that there was no bleeding. So I did not encounter any massive bleeding from obturator vessels. Now to conclude this case series, I would say that a controlled soft tissue release followed by placement of retractors at 3, 6, 9 and 12 o'clock positions is an easy and reproducible method for achieving 360 degrees acetabular exposure during total hip arthroplasties for various hip pathologies. Thank you so very much.
Thank you, Dr. Kumar. And I think that has improved your understanding of acetabular exposure. I think the critical thing is to basically place your retractors correctly, place your pins also correctly, and whatever retractor. I think there's so many retractors that are available now. It can be placed effectively, and I think the understanding of a 360 exposure is absolutely good. In the sense that is how it will improve your exposure.
Thank you, sir.
Can you call upon Dr. Daksh Gadi to present his case, please?
Dr. Kumar, you have any tips for the youngsters while putting in the pin, the posterior pin near the sciatic nerve? Do you have any tips to prevent the injury to the nerve?
Use the mic.
Why I use the pin or where I use the pin?
No,
Not
any
why or
tips,
where.
any
How do you prevent the sciatic nerve injury while putting that pin? How do you make sure you're not putting that pin on the nerve?
I take off a part of the capsule from the posterior edge of the acetabulum, and then I take bite from the short external rotators. So I pull the short external rotator posteriorly, so that takes the posterior sciatic nerve a bit more posteriorly. I have already exposed the capsule from the posterior aspect. At times I also take some bite in the posterior capsule. I pull it posteriorly, then the bone is exposed right in front of me. So I get around a centimeter of bone over there. I try to be as posterior as possible because I have a cushion of the capsule and the short external rotators. So bone has to be exposed in an adequate manner before you put the pin.
The problem with, one of the problems you are likely to face when you put those pins is, I think what Mrinala was also trying to ask, one, it can break. Number two, it can come in the position of your screws if you need to add screws for your acetabulum. So that you should be careful about.
The superior pin at times come while we are putting the screws. And so
Correct.
at the last step, by the time we are putting the screw, the acetabular cup has already gone.
So you take out,
we take out the
so sometimes if you tap 2-3 times, that can alter the trajectory of the screws also. So that's why in a general exposure of the acetabulum, nobody uses pins there. The general description is to put it on the ischial tuberosity or if necessary. But I think more often than not, everyone when you do posterior, get comfortable with the way you place your retractors. With 2 or 3 retractors, you should get a good 360 exposure.
Even if you want to put that pin, I would suggest you use a cautery before you hammer that pin. That will tell you that the nerve is too close to that.
If you want to put a pin.
Yeah.
Okay. Yes, Dr. Dakshkari.
Thank you, the organizing committee and Dr. Prasad, for inviting me. So I'll be presenting a case. It is a case of a 35-year-old male patient who presented to me with a history of trivial fall. He had a past history of THR for AVN of left hip 2 years back. And he was a known case of spinocerebellar ataxia and was on neurological treatment. And he had developed AVN due to high-dose steroid intake. Also, he had a history of a tibial plateau fracture which was operated and plating was done somewhere else. So just briefly, spinocerebellar ataxia. Ataxia, which is described as poor muscle control that causes clumsy voluntary movements, associated with difficulty in walking, balance, hand coordination, speech, swallowing, and eye movements. Somehow all these features were present in my patient, and it is mainly caused by cerebellar dysfunction. So this was the X-ray on presentation, and I got a long full femur X-ray to look for the bow of the femur. And based upon Vancouver classification, which is a treatment-based classification, this fracture was classified as B2 fracture, which was around the stem and with loose stem, but good proximal bone, and revision of femoral component was planned. So my plan was to revise THR.
You had an acetabular issue also, because it looks like there's an acetabular fracture as well.
So I'll be presenting it.
Okay.
I had not got a CT done somehow.
Pardon?
I had not got a CT done.
You didn't get the CT done?
Yeah, didn't get a CT done. And this was, so I had a plan of revising with Wagner stem, not solution. I had kept both the stems, and using connecting cables and periprosthetic locking plate was also put, in a backup. And as a backup, I had a dual mobility cup also present. So I usually do in all hips in Harding's approach, modified Harding's approach, so I did it in that only. And the previously primary appeared to be done by posterior approach. So intra findings, acetabular cup was well fixed, so I didn't touch it. Stem was proximally porous coated and was loose, partially lateral osteointegration was noted. And the fracture, as shown in the X-ray, it was a long posterior-medial spiral fracture fragment was there, involving the lesser trochanter. Separated GT and shaft were found. So, intraoperatively, using multiple bone-holding forceps, reduction was done and was held by a partially tightened SS wire. The third wire is basically SS wire, will be shown later. And on only distal femur canal was reamed, and it was found to be quite narrow. 12 mm reamer was not being able to put, and so as more than 10.5 mm reamer was not being able to pass, so board 10-inch solution stem and Wagner stem were ruled out. Because Wagner, we had no availability of a lesser size stem, and 10.5 mm 8-inch solution stem was used with using 4 control cables. Basically the third cable is the SS wire, which was previously held while reaming the canal. So this is the post-op X-ray, and post-op X-rays, mid and lateral views. Follow-up X-ray at 8 weeks. So this was the walking video. This is the, at 3 weeks I had started weight bearing because the patient was a cerebral ataxic patient, and with very clumsy movements, ataxia was there. Walking videos at 4 months, using walker. I have advised him to walk with support only, because chances of recurrence of fall and injuries are very. And there was a tibial plateau fracture which was operated.
Show us the 6-month post-op X-ray.
So I have the latest X-ray of 8 weeks.
Yeah,
There
see,
was a
it's
good
always
look.
advisable when you're taking an X-ray, especially take an X-ray of both hips, because the single hip will not give you an idea of how much, the simple reason being, if you look here. So you've done that. This is post-op.
Yes, sir. This is
No, we
the
are talking about the follow-up.
follow-up. Both hip X-ray is not there. Follow-up.
No, it's always advisable to take both hips because you will not know otherwise whether length and whether subsidence and all those things you have to compare. Number one. Number two, if you look at the position of the screws there, if you compare the established screws for the first X-ray to the, I don't know whether it's rotated. We are not able to comment whether it's rotated, whether it's changed position, but obviously the screws have changed position. And it would not be advisable, especially in a patient with that mobility pattern, to leave the acetabulum without additional fixation, especially when you suspect a fracture. Either it should have been revised or it should have been anchored with additional. So if you carefully look at the position of the screws from the initial X-rays, obviously the screw position has changed.
No, there seems to be signs of acetabular loosening.
Yes.
And the other thing what you notice is this patient is walking with extreme external rotation. So how do you explain that?
Sir, previous gait of the patient, I don't know, before the surgery. The version which, according to the cup, I had not revised the cup. So the version which was checked on table.
No, I think the socket is falling into retroversion. And that patient is compensating that by external rotation. And you can see from this X-ray that this cup appears retroverted from the AP view.
I totally agree. And that is why he's compensating by externally rotating, otherwise it would dislocate posteriorly.
Okay.
So it's just a matter of time, I think it might become loose further. This
Sir,
cup, you
sir.
need to wait and watch. This should have been revised day one.
Good that you use a solution stem, but what you can do is, especially when you ream to 12, a Wagner 14 also would have fit in, because remember it's a tapered stem. Wagner is a tapered stem. It's not a cylindrical stem.
Sir, I had kept it on table and I was preferring titanium stem only, but somehow the reamer was not passing. Even the 10.5 was very tight.
No,
And
so if you prepare with the Wagner reamer, that is a conical reamer. So that you will be able to definitely fit in a Wagner 14. Simply because remember it's a tapered stem. So a Wagner 14 tapers down to almost 8.7. So that easily fits in and that gives you a good fit. And not only the fit, remember people are moving away from the fit and fill philosophy of this solution stem to a tapered fit stem because it gives you a better fit. The offset is better, things are better. Anyway, this is just for, but this was well done, no issues about it.
Okay.
And also, only thing is, you should probably just looked at that X-ray and checked intraoperatively for the acetabulum. That's the only,
Yes, sir.
otherwise well done.
See, sir, I had told him that he might require acetabular revision later, but because intraoperatively I found that the cup was good, well fixed, so I didn't touch it.
So the
and
simplest thing that could have been done, simplest thing, if you thought the cup was stable, you could have just taken out the liner and put in additional screws all around. Because that itself will act like a fixation. Use multiple screws.
Yeah, it was a multi-hole cup mostly.
That looks like a multi-hole cup
Because
to
it
me.
was
See,
a
can you see
Zimmer
that?
cup.
It is a multi-hole cup. If you looked at the X-ray, it is a multi-hole cup. If you look carefully, it is a multi-hole cup.
Yes,
so you
sir.
had that option without changing the cup.
Yeah, that's a good idea.
So that's why we said, I mean, that would have been a conservative sort of revision. Just take out the liner, add screws all around, and you would have, pardon? Offset line. Yeah, and then you can get an offset line. So just that, pick up these points so that you don't have to go
Yeah.
in for a detailed revision.
Yes, sir.
Anyway, well done otherwise. We move on to the next presenter, Dr. Santanu Sharma.
So,
Well done.
Just a little take-home message, spinocerebellar ataxia is a relative contraindication for hip replacement surgery. High chances of failure, periprosthetic fractures, dislocations due to frequent falls may occur. Primary replacement should be avoided, and if very essential, then dual mobility cups may be used to avoid dislocations. And gait training may be helpful after primary replacements. Thank you.
The order then.